This is the first slide in gallbladder. The objectives include brief speaking about anatomy, investigations, congenital anomalies, choledochal cyst, gallstones, including types and etiology, effects and complications, or presentation of gallstone. The gallbladder and bile duct anatomy. It is pear-shaped. Gallbladder is pear-shaped. It is around 7.5 to 12 centimeter in length. Its capacity around 50 ml. It consists of fundus, body, neck, and infundibulum. The cystic duct is around 2.5 centimeter in length and 0.5 centimeter in diameter, joined common hepatic duct, which is around 2.5 centimeter in length, to form complete common bile duct, CBD, common bile duct, which is around 7.5 centimeter in length. Blood supply of gallbladder is cystic artery, which is a branch of right hepatic artery. Now, caterpillar term, it is one of the anomalies of vascular supply near the gallbladder, which is tortuous right hepatic artery in front of origin of cystic duct with short cystic artery. This is important for surgeon to detect such anomalies because this is the area of dissection of triangle of Callot during laparoscopic cholecystectomy. Lymphatics, two ways: one to cystic lymph node of Lund, which goes to celiac lymph node then, or two directly to the liver. Physiology: bile consists around 97% of water, 2% bile salt, 1% bile acid and cholesterol. Bile production is around 40 ml per hour, which is around 1000 ml per day. Gallbladder function: it is 1. Reservoir and storage of bile. 2. Concentration of bile 5 to 10 times. 3. Secretions of mucin, which is around 20 ml per day. Investigation of biliary tract. Number 1. Plain X-ray. It gives radio opaque stone to around 10 to 20%. And to detect porcelain, gallbladder, and limy bile, and sometimes gas in biliary tree. 2. Oral cholecystography and IV cholangiography. It is out of use nowadays. It is mentioned here for historical interest. 3. Ultrasonography. This is the important one in gallbladder diseases. It is a prime test. It is a standard test. It is a quick and non-invasive test. Number 4. ERCP and endoscopic ultrasonography. This is already mentioned in first lecture about investigations of hepatobiliary system. Number 5. PTC, which is percutaneous transhepatic cholangiography. Again, this is mentioned in detail in the first lecture. Number 6. MRCP, magnetic resonance cholangiopancreaticography, which is a standard and no contrast needed. Number 7. Radioisotope scanning, which is 99 technetium 99M, labeled HIDA scan. This material given intravenously and extracted in bile goes toward gallbladder, and then gallbladder visualized within 30 minutes. If delayed to 1 hour, suggest acute cholangitis or contracted gallbladder in case of chronic cholecystitis. Number 8. In investigation, CT scan to detect liver and pancreatic lesions, to detect cancer extent and staging, and to detect lymph node enlargement. Number 9. Per-operative cholangiography, and lastly per-operative choledocoscopy, which is a flexible fiber optic endoscope to localize and extract the stones. Congenital anomalies of gallbladder and bile ducts. 1. Absence of gallbladder. 2. Phrygian carb, which represent around 2 to 6%. Phrygian carb, like hearts of people of Phrygia, Asia Minor, which is just like septum in gallbladder, either complete or incomplete. 3 anomalies: intrahepatic gallbladder. 4 floating gallbladder, and sometimes this leads to torsion of gallbladder. 5 double gallbladder. 6 cystic duct anomalies, for example intrahepatic, accessory duct, low insertion, short or absent. Other anomalies is extrahepatic biliary atresia, which represent 1 out of 14,000 live births. This happened in 1 out of 14,000 live births. It is occlusion of biliary tree of variable lengths, to start with inflammation, leading to destruction, resulted in fibrosis, ended with obliteration. And the outcome of this anomaly: 1 biliary cirrhosis, 2 portal hypertension, 3 jaundice, and lastly liver failure. Types: type 1 occlusion of common bile duct, type 2 occlusions of common bile duct plus common hepatic duct, type 3 occlusions of common bile duct plus common hepatic duct plus left and right hepatic duct occlusions. All the ducts will be occluded. Clinical features: 1 jaundice at birth, which is a progressive one; 2 pale meconium; 3 dark urine; 4 steatorrhea leading to osteomalacia, which is called biliary rickets, in addition to clubbing of fingers, portal hypertensions, and presence of other anomalies in 20% of cases. Differential diagnosis: 1 neonatal jaundice, 2 choledochal cyst, 3 inspissated bile syndrome, 4 neonatal hepatitis. Treatment: early surgery in terms of Roux-en-Y hepaticojejunostomy or liver transplant. Postoperative complications include 1 cholangitis in 40%, 2 portal hypertension in 50%. Choledochal cyst definition: congenital cystic dilatation of biliary tract, particularly common bile duct, particularly CBD. Clinical features: jaundice, right hypochondrial cystic mass, and lastly cholangitis and pancreatitis. Diagnosis: ultrasound is a very good diagnostic tool. 2 MRCP, that is magnetic resonance cholangiopancreatography. Treatment: because it is premalignant leading sometimes to cholangiocarcinoma, so surgical excision is the treatment of choice with Roux-en-Y. Surgical excision is the treatment. Let us start to speak about gallstones. This is an important title. The gallstone. This table summarizes the types of gallstone. First of all, we got cholesterol stone, then mixed stone, black pigmented stone, and then brown pigmented stones. And I summarize it in one table in order to make comparison between them. Location: the cholesterol stone located in gallbladder, mixed stone in gallbladder, black pigment stone in gallbladder, while brown pigment stone in bile duct. Component: cholesterol stone composed of almost pure cholesterol, while mixed stone mostly cholesterol. 51 to 90% of stone is cholesterol plus calcium, salt, bile acid, bilirubin pigment, and phospholipid. While black pigment stone consists of mostly of bilirubin pigment plus calcium phosphate plus calcium carbonate plus 30% cholesterol. While in brown pigment stone consists of 30% cholesterol or less, and mainly consists of calcium bilirubinate plus calcium palmitate plus calcium stearate. Gross feature of cholesterol stone is large, solitary, and white, while gross feature of mixed stone small, hard, multiple faceted, green or yellow. While black pigment stone, the gross feature small, black, irregular, and multiple. While brown pigment stone looks large, brown, and single. Common possible etiology. The most common possible etiology of mixed stone cases in which cholesterol increase or bile acid decrease in bile associated with patient with obesity, high caloric diet, contraceptive pills, ileal resection, abnormal emptying of gallbladder, and the same possible etiology for cholesterol stone as well. So cholesterol stone, mixed stone, same common possible etiology. While in black pigment stone, the common possible etiology is highly associated with sickle cell anemia and hereditary spherocytosis and cirrhosis. Brown pigment stone, common possible etiology is associated with bile stasis and infected bile due to foreign body in bile duct like stent or parasitic infestation like chlororiches, sinensis, or scars lumbricoides. Word distribution. Cholesterol stone in US and Europe 80% cholesterol or mixed stone. Around 10% of them is pure cholesterol stone. Word distribution for mixed stone in US and Europe 80% cholesterol or mixed. Around 70% of them is mixed stone. Word distributions for black pigment stone in US and Europe, both types of pigment stone represent around 20% of total, mostly in immigrant people from Asia and Africa. In Asia, 80% of stones are pigment stone, black more than brown. Word distribution in case of brown pigment stone in US and Europe, both types of pigment stones represent around 20% of total, mostly in immigrant people from Asia and Africa. Common in Asia. In Asia, 80% of stone are pigment stone, black more than brown. This diagram summarizes many of causes or etiology of gallstone. Many of them already been mentioned in the table in previous slide. Effects and complications of gallstone. This is very important slide, and I need to give a focus for this point that the acute cholecystitis is not the similar name for gallstone. I mean, gallstone could present in different ways, including acute cholecystitis or other presentation. So these are the other presentation or effects or complication. Number one, effects and complications or presentation in gallbladder. Number one, silent, asymptomatic, and this is most common type, mostly. Two, patient might present with dyspepsia, flatulence, food intolerance for fat, particularly fat. 3. Biliary colic. 4. Cholecystitis, acute and chronic. 5. Fistula leading to Maurice syndrome, less than 0.1%. 6. Mucocele. 7. Empyema of gallbladder. 8. Gangrene and perforation. 9. Carcinoma of gallbladder. And sometimes effect and complication included in bile ducts other than gallbladder, and these are 1. Jaundice. 2. Acute cholangitis. 3. Acute pancreatitis. In addition, effect and complication of gallstone affecting intestine, and that's what we call with intestinal obstruction gallstone ileus. Okay, this slide represents the same information in the previous table. In the previous slide, I put it on this diagram in order to understand what is happening. So this is number 1, representing a stone inside the gallbladder and nothing happened, which is called asymptomatic presentation, asymptomatic stone, and sometimes only flatulent dyspepsia, and that's it. Number 2, when stone intermittently obstructing cystic duct or come here causing intermittent biliary colic, and then after a while the stone turn back to the lumen of gallbladder. This is what we call the biliary colic. Or 3, when the stone impacted in cystic duct causing acute cholecystitis, and then it might relieved and get other attack, still reaching to fibrotic and contracted wall of the gallbladder and causing chronic cholecystitis. Or 4, here the stone come in cystic duct and compressing or fistulizing into common bile duct causing Maurice syndrome, which represent less than 0.1%. Or here 5, look, the stone reaching to the lower part of common bile duct and impacted in distal part of common bile duct causing jaundice, biliary colic type pain, and risk of ascending cholangitis or acute biliary pancreatitis if it is obstructing the common lumen, common channel, because here many patients the end of CBD and end of pancreatic duct opened in one point, which is called ampulla of water. And here number 6, when stone eroding through the gallbladder into the duodenum, for example, resulting in cholecystoenteric fistula, and this is, and then the stone passed to the duodenum and jejunum and then ileum, causing obstruction, what we called it gallstone ileus. And number 7 here, for example, as you could see in the diagram, long-standing cholestasis resulting in gallbladder carcinoma. So big long-standing stone pressure effect on certain site of gallbladder leading to malignancy, which represented in less than 0.1%. In addition to mucocele and empyema and gangrene perforations already been mentioned in the table. So these information already mentioned in the table in the previous slide, but I put it here in the diagram in order what is happened, what are the different outcome, what are the different effects, what are the different presentation of gallstone. Not any gallstone is called acute cholecystitis. Look, no, gallstone might present with different presentations, starting from asymptomatic to flatulent dyspepsia, to biliary colic, to acute cholecystitis, to chronic cholecystitis, to Maurice syndrome, to obstructive jaundice cholangitis, to pancreatitis, to gallstone ileus, to malignancy in the gallbladder, to mucocele, empyema, gangrene, and perforation of gallbladder. So different presentation, as I already mentioned that in the slide. Now in this slide, I would show you how could the patient present. We know in the previous slide that the types of presentations and underlying pathophysiology, what's happening in order to get the different presentation or outcome or effect or complication of gallstone. And we gave any one of these effect a name. Now let us start to speak how to present these effects or outcome. The outcome of gallstone, for example, let us start with silent. What are the clinical features? Most of patient asymptomatic. This is number one. Number two, if the patient presents with flatulent dyspepsia, the answer is clinical features: dyspepsia, right hypochondrial pain or epigastric pain, more often dull and constant, plus flatulence plus intolerance of fatty food. Number three, presentation, outcome, effects, presentation, complication. All these are the same names for what is gallstone achieved. Now, biliary colic, I said silent, I spoke about it. Flatulent dyspepsia, I spoke about it. Now, biliary colic, 10 to 20% of patients of gallstone. History, several episodes of pain, which is severe, lasting from minutes to hours, plus nausea and vomiting for few weeks, then period of relief for few months as the stone disimpacted back into the gallbladder. During clinical examination, negative Murphy sign and no fever, because there's no inflammation in the wall happen, and obstruction relief because the stone returned back toward the lumen of the gallbladder. This impacted. And ultrasound, no sign of acute cholecystitis, but there is stone only. Blood investigation, no significant changes in laboratory data, may be silent, slight rise in liver enzyme and bilirubin. No significant change in laboratory data. That means normal white BC and maybe slight rise in liver enzyme and bilirubin or no change. And then acute cholecystitis. Acute cholecystitis. So I spoke about silent, flatulent dyspepsia, biliary colic. Let us start to speak about acute cholecystitis. In acute cholecystitis, the patient got in history right hypochondrial and or epigastric pain, which is much more severe than previous three presentations. In examination, there is tenderness right hypochondrial region, plus Murphy sign positive, plus low-grade fever. Look, there is no tenderness, no Murphy sign positive, no low-grade fever in biliary colic, in flatulent dyspepsia, and in silent. Now, this is a new finding in this presentation. Tenderness, Murphy sign positive, low-grade fever. And ultrasound show signs, ultrasonic features of acute cholecystitis, which is distended gallbladder, presence of stones, thickened wall of gallbladder. Here, this is the important, distended and thick gallbladder wall, plus pericholecystic fluid collection. These are the ultrasonic feature of acute cholecystitis. And the blood investigation, leukocytosis, white PC increase, and moderate elevation or changes in liver function test. Look, in biliary colic, ultrasound normal, no ultrasonic feature of acute cholecystitis. Look, blood investigation in biliary colic, no changes, white PC normal, no changes in liver function test or slight rise. But here there is a changes in white BC in acute cholecystitis, increased white BC, and moderate elevation or moderate changes in liver function test. And here the signs Murphy present, there is no Murphy sign. Here in acute cholecystitis, Murphy sign positive, while in biliary colic, Murphy signs negative. Here there is low grade fever in biliary colic, there is no fever at all. Here, ultrasonic feature of acute cholecystitis in acute cholecystitis, which is I already mentioned them here, while in biliary colic, no signs of acute cholecystitis in ultrasound. Okay, let us proceed. So I said silent, flatulent dyspepsia, biliary colic, acute cholecystitis. Now, empyema of gallbladder. Empyema of gallbladder, same of acute cholecystitis, plus history of acute attack that hasn't relieved, plus more pain, more tenderness, sometimes more fever, increase in pulse rate, and might be palpable mass in right hypochondrial region, gallbladder surrounded by omentum. Then other presentation, perforation and hair signs and symptoms of peritonitis, usually localized. Hair sign and symptoms of peritonitis, or acute abdomen, usually localized, which is tenderness, rigidity, tachycardia. Okay. And the other presentation is chronic cholecystitis. Here, history of acute attack that has already been relieved. When we ask the patient, he got a previous attack or many previous attacks of acute cholecystitis. Then pain here is less in severity and frequency, plus might be flatulent associated with flatulent dyspepsia, plus nausea and vomiting. In examination, look, in chronic cholecystitis, no fever or tenderness. While I mentioned in acute cholecystitis, there is low-grade fever, there is tenderness. In chronic cholecystitis, no Murphy sign negative. Why? Because there is a shrinkage in gallbladder. While in acute cholecystitis, there is a Murphy sign positive, because the gallbladder distended. In ultrasound, here we could see shrinkage of gallbladder. Look, in ultrasound here, in chronic cholecystitis, there is a shrinkage of gallbladder. While in acute cholecystitis, I say distended gallbladder, here shrinkage, because it's exposed to many times of inflammation and infection, and then ended with fibrosis and become shrinkage and small. Plus, yes, I'm saying that ultrasound feature shrinkage of gallbladder plus presence of gallstone plus no signs of acute cholecystitis. Blood investigation often normal. White BC normal, liver function test normal. Look, while in acute cholecystitis, white BC increase, liver function test is moderate elevation, moderate changes in liver function test. Thank you very much.